Good evening, everyone. My name is Dr. Ganesh Kumar. I work as a scientist and heading the Division of Non-Communicable Disease at Indian Council of Medical Research, National Institute of Epidemiology. Today, I will be introducing our speaker on our implementation research webinar series, Dr. Prabhdeep Kaur. Dr. Prabhdeep Kaur is a professor, Issac School of Public Health, Indian Institute of Science, Bengaluru. Dr. Prabhdeep Kaur has 20 years of stellar public health experience, focusing on the area of implementation science for non-communicable diseases, interventions and policies. She had conducted many epidemiological research on various entities, which includes hypertension, cardiovascular disease, chronic kidney disease, and cancers. She was leading the India Hypertension Control Initiative, which is a multi-partner initiative, a very big implementation research project in order to improve the control of hypertension treatment and control in public health facilities in more than 150 districts of India. She has provided technical support in initiating and introducing the HPV vaccination in Punjab, India. She has also conducted chronic kidney disease of unknown origin hotspots in India in collaboration with the partners and degree collaboration group. We are really proud to have you here, madam. The stage is over to you, and please take over the stage.
Thank you, Dr. Ganesh, for the kind introduction. So, hello, everybody, and good evening. And I'm sure many of you are traveling back from work or just winding up your day. So we hope to make this webinar interesting for you and meaningful for whatever implementation research you may plan to do in the near future. I will be sharing my screen now. Ganesh, please confirm my screen is visible.
Yes, it is visible, ma'am.
Okay,
yes, it
great.
is visible.
Okay, thank you. So today we will be talking about how do we frame implementation research question and objectives. And you must be thinking, it seems like a very fundamental thing. And why did we choose this as a webinar topic? So I just want to give you a little background. I recently joined Indian Institute of Science, but until last year, I worked with ICMR. And last year, when we were reviewing various applications that we received for our extramural research program, especially on the implementation research vertical, which is called delivery vertical, we realized that several people had difficulty in deciding whether their project was actually an implementation research project. And it was quite evident when we read their objectives and method section and so on. And one of the commonality that came across was that the research question was not adequately well thought of, partly because people had a lot of difficulty in understanding whether it was an epidemiological research, whether it required an intervention trial, or whether it required an implementation research. So we felt that although looks very simple, but maybe it's not all that simple. And hence the motivation to keep this as one of the webinar topic. As you know, the webinar series has been ongoing, and this is fourth talk under this webinar series. So just to set the stage for today, if you go to the WHO TDR website, you will find this scope of implementation research. It is a systematic approach to understanding and addressing the barriers to effective and quality implementation of health interventions, strategies, and policies. What is very unique about implementation research is it is demand-driven. And the research questions are framed based on the needs which are perceived by the stakeholders or the implementers who are working in the health system. So I think that's the most important thing I would like to convey today, that you cannot just sit in your own room and come up with a good question for implementation research, because that question has to be embedded in the reality of health system, in the health programs and interventions which are being implemented. So fundamentally, for you to come to a good research question, you need to go through a process, and that process cannot be done alone. That process need to be done along with the stakeholders. So the process to generate the research question can be very difficult and tedious process. Of course, we all know that we should conduct literature review, and that is something most people do when they are writing a research proposal. But you know what happens is literature review may come from other settings, may come from other countries, and may be looking at an intervention which is little bit similar or different from the intervention which you are thinking of working on. Hence, the discussion with stakeholder becomes an extremely important next step, wherein you envisage an intervention, but then you also talk to the real stakeholders who are going to implement that intervention, or who are going to maybe come up with a new policy framework to enable that intervention to be embedded in the health system. And these stakeholders may include policy makers, program managers, healthcare workers, which is your doctors, nurses, ashas, and so on, experts, people who have worked in that particular area, and most importantly, patients, because sometimes you may think some intervention is great, but patients may not accept the intervention, which may make it really hard for you and as well as your health system stakeholders to implement that particular intervention. Now, that itself may not be enough sometimes, because there are field challenges which may not be written on any document, and which definitely are mostly not documented in the literature. And hence, these challenges might be the reason why a particular intervention is not getting implemented as envisaged. And the way to overcome this is you actually do field visits and you interact with people. You see how that particular program is being implemented. And once you have seen, you have read about it, and you have heard about it from your various stakeholders, that is when you actually start the process of framing a good research question. Now, when we talk about the literature review, what is that you should look for in the literature review to come at a good research question? Of course, you should understand how common that condition is, what is the burden, whether it's a condition which is increasing, whether it is the prevalence is increasing or the mortality is increasing, which makes it really important for you to think of very effective interventions, or it is a condition which might be on decline, and hence maybe you don't need novel interventions. Before you really get into doing any intervention, I think it's important to ask the question, do we really need to do it? Are the things already there, and are they working fine? Are they being implemented as per the plan? So there has to be a clear understanding whether you are thinking of introducing a new intervention which is already not in the system, or you just want to optimize an existing intervention. And quite often, it's the optimization bit which is very difficult. And it is that component of implementation research which can make a huge difference. Sometimes by making small changes, by tweaking things little bit here and there, you might be able to actually improve the way that particular intervention is being implemented. Now, if it is an existing intervention, I think the two important questions you need to ask before you jump to an implementation research is there an evidence that this particular intervention which we are talking about, it has already been shown to be efficacious, which means there has either been any kind of research, RCT or other, could be quasi-experimental studies, especially in context of complex, large, community-based intervention, which showed that the intervention works. Now, it may not always be in your setting. It could also be in another setting or in another country, but you should look for that evidence. And if such an evidence does not exist, then this is not something you should be taking to implementation research. Maybe you need to actually do an efficacy study first before you move on to and implementation research study. Of course, this talk is restricted in terms of research questions and objectives. There are study designs where you could test your effectiveness and also look at some of the implementation aspect all at one go. However, I would recommend, especially if you are an early career researcher, it is better to look at interventions which are already proven to be effective and hence focus purely on your implementation aspects of it and make your research question very, very crisp. Now, the second thing which we need to keep in mind is this intervention cost effective? It might happen that there is an evidence that the intervention works. However, we do not have adequate evidence that it is cost effective. Again, in such situations, it may not be a good idea to jump into implementation research, because even if you find everything to be fine, it's a good intervention and you are able to overcome all the implementation barriers, but then you take it to your policymaker and say, look, I want you to fund this. And the government may come around and say, look, no, I'm sorry, I have many things to fund and this is not high on my priority. And then you may feel that, all your effort got wasted. So I think it's really important to spend a lot of time thinking about what is a good implementation research question and grounding your question in the reality, grounding your question in the science, and knowing whether you should really be investing your time and effort on this. The next important thing you need to keep in mind when you look at an implementation research question is, are you trying to address a knowledge gap or are you trying to address a practice gap? If you look at most of the implementation questions, they are around practices. Quite often we know what to do, but we are still not doing it. There are any number of examples of that, and we will be in the subsequent slides spending a lot of time today talking about these examples. Now, quite often people say, okay, yeah, I know there is efficacy data available, but it is there in some other setting. And if that is a situation, that is a good sort of a setting where you could think of moving to implementation research, because you know this particular intervention works, but you don't know how to embed it in your health system. So you do have evidence and you know it is a scientifically proven intervention, but all you need to figure out is, okay, in given my state's health program or my national program or the resources which I have in my country, can I fit this particular intervention into my system? So this is broadly what you need to look at, apart from talking to people and visiting in the field and understanding what's already going on in the health system and where you want to make these changes or do optimization. So just broad message I want you to keep in mind, that implementation research is relevant only when you know what the intervention is and it is evidence-based. So if you haven't reached that step, please do not write proposal for implementation research. Maybe you need to do some other kind of research. Maybe you need to work on development of an intervention, or maybe you need to do a kind of trial to see whether your intervention is effective. If you have crossed all those levels, only then where you are trying to figure out how to implement this effective intervention, that's when you jump into this aspect of research. Now, before I go into some of the questions that we will be discussing today, just going by our experience and the kind of proposals that ICMR receives, I wanted to just explicitly put out there what is not implementation research. So if you are doing epidemiological study, for instance, you want to measure prevalence, you want to measure incidence, or any kind of measurements related to burden of a disease, that is not implementation research. If you want to describe distribution of a disease, for example, disease X, how it is distributed in a particular state or in a particular city, which age group is affected more, and how is it changing over time. It is not implementation research. If you are planning to test a hypothesis, either in a case control study or a cohort study, to understand the risk factor of a particular condition, it does not fall in the domain of implementation research. And finally, if you are doing a trial, for example, a RCT, to test whether a particular intervention has an efficacy or not, again, it's not within the scope of implementation research. So I think before you move on to writing your proposal, ask yourself question, uh, what type of research am I planning to do? Does it fall within the scope of descriptive research? Is it testing an intervention? Am I measuring efficacy of an intervention? Or I know the intervention, but I'm trying to figure out how to get it implemented in a given health system. So the type of questions that you answer in any implementation research study usually begin with how and why. So you want to understand how to embed a particular set of intervention or strategies in the health system. Or sometime you have already implemented an intervention, but you're not able to figure out why is it not working? Why are things not working if I have the human resource, if I have put in the effort, I have done the training of health worker, but I'm still not seeing the results. So these are the kind of questions that you can answer through implementation research. So some of the examples which I will be talking in the subsequent slide will broadly follow a pattern. And I just made some points here just for you to think through what these questions can be. The questions might be looking at understanding enablers or the barriers to uptake of a particular intervention, understanding how an intervention fits in a specific context, in a specific geographic region. See, let's say, for example, you have already got an intervention which is working perfectly well, let's say in many districts in a state, but is not working in two districts. Now, it could be that those districts are tribal or they are hilly, or like what we have aspirational districts, which are relatively less developed. And hence things are not working, and maybe you need to tweak it. So to understand how to fit it into a particular context. Or it could be that certain target groups are not using your intervention. For example, certain intervention are more acceptable to women compared to men. So why are men not coming forward when I'm providing the same input, I'm doing the same kind of education, I'm doing everything same, but women are taking up and men are not taking up? So you need to answer that why. Understanding existing processes. Sometimes what happens is that we have ongoing programs and healthcare workers are used to doing things in a particular way. And when we try to introduce something new, they just don't know how to fit it into their workflow. Or there could be real challenges in how a new intervention need to be embedded in the health system, either in terms of resources or in terms of workflows or in terms of information systems and so on. So there could be questions around that which can be addressed through these studies. Next important area where IR comes really handy is scaling, because you have now found something which works, you know it is effective, but you just don't know how to take it to scale. Because if something works, let's say in 20 PHCs, that doesn't mean it's going to work in 100 districts. It may work, it may not work. But when you go, let's say from 20 PHCs to 100 districts, it may happen that you come up with so many more new challenges which you didn't think about. So when you go from a research mode to a scaling mode, you need to understand what kind of optimization might be required or what kind of additional resources might be required. Sometimes it could also mean that you will end up changing your intervention altogether because it just worked well for 20 PHCs, but it's just not meant to work at scale. And I can tell you, given my experience, that there are many such interventions which have worked really well in research mode, but when we took them to scale, they just don't work. And finally, one very important new area where implementation research is widely used, and I feel we should be using more of it, is really on quality of care. So you already have put a system in place, you already have implemented a particular set of interventions, but you are not getting optimal results. You are getting results, but you know that you can actually get better patient outcomes. So somewhere along the line, the quality has got diluted. And understanding where those bottlenecks are and addressing those bottlenecks can make a huge difference in the patient outcome. So you may not actually need to do new things, but you may need to do things differently. So this is the broad scope of questions which can be answered through implementation research. So what I'll be doing in the subsequent slides, I'll be sharing with you some examples from my own experience, and I have my colleagues here in the webinar today who will also be sharing their experience around some particular questions. Considering the time constraint and considering that today's webinar is focused on research questions, we will not be going into the methodology part. However, if you have questions, you can always email us later. So today, what we will try to come up with, and what my goal at the end of this 1.5 hours is that when you start writing a proposal, you should be able to make a decision whether I'm asking an implementation research question and how I should be writing my objective. And I think if you can get that right, I'm sure you will figure out all the rest. So here is this a study we recently published just a few months back, and I'm taking this because it's very relevant to uh, current situation in India. We know that under the Ayushman Bharat initiative, we have health wellness centers, and one of their mandate is to actually manage, follow up, and provide monitoring for people with NCDs. So when this whole initiative began, we were already working with various governments in India, and we knew that this is going to be a huge challenge to embed this new kind of care system in our health system. So what we did was under the India Hypertension Control Initiative, which is basically a multi-partner initiative, where we had a set of defined strategies which are already evidence-based, cost-effective, and we were trying to embed these strategies into the health system. And in that process, since we were very fortunate that while we were doing this project, that's when the health wellness centers program was introduced by government of India. So we started working with the governments in many of these states, and we told them, fine, you already have these guidelines. Government has already told that these 1, 2, 3, 4 set of packages should be done at the health wellness centers. What we would like to do is work with you to understand how these processes can be embedded in the day-to-day work of nurses. What are the challenges? How to overcome these challenges? And along with that, we will also measure whether doing all these processes, we were actually able to embed this whole new set of interventions in the health system. So this paper, of course, is available. I have given the reference here. You all can read. But I'm just using this as an example to introduce you to the concept of how to ask a question. So the question here is, how can we decentralize hypertension care to health wellness centers? And why is it an important question? Because when we collected and analyzed data across many states in India, we found that large proportion of patients were taking care from district hospitals. And then there were other states where primary health care system was a little bit better developed compared to, let's say, few states which have more of, people going to district hospitals. There were, let's say, 50-60% people who are going to primary health center or community health centers. And we also tracked over a period of time, and we were able to see that clearly people who went to district hospital, they had the highest chance of dropping out. They just don't come back to care. Next is community health centers. People who went to community health centers, again, due to distance and all, it was better than district hospitals. They were more likely to stay on treatment, but definitely not as good as it could get. We wanted to improve retention in care and control of blood pressure. So the idea here was, how do we do this whole process of changing the patient behavior, that they should not go to the higher facilities, but go to the peripheral facilities. So that is from the patient perspective. But more importantly, we had to do changes in the health system itself and try to see what all processes need to be in place so that the care can be given. So let's say we tell the patient that you go there, but when you go there, you should actually get the care. Because if patient goes once and they don't get the care they want, they will lose interest and not come back. So here you can see now, the question is, how do we do this process? So it begins with how. As I said, the IR questions should begin with how. And the objectives, there you can have multiple objectives in an IR study. So one, we wanted to really document each and every process that we had to design to ensure that this care can be provided. It could mean for new patients, it's easier, but for patients who are already under care, it literally meant changing their health seeking behavior. And secondly, we also wanted to see that, okay, fine, having implemented, having put these processes in place, did we really improve the outcomes? Did we really improve the blood pressure control? Were we able to retain more people in care compared to what it was before this intervention began? So just to give you a glimpse of what was done, so you understand the connection between the question objective and what we measured, we documented the process at all levels, starting from governance and financing. Do we have adequate budget available for these centers to, let's say, procure drugs or do any diagnostics? Do we have BP monitors available? Do we have these? We said that the health wellness centers, but do we really have? I think someone needs to mute.
They are in a meeting right now. Are to go and tell them, just go and say, can I?
Yeah, thank you. Do we have the staff actually available to do these services? If so, are they trained? Do we have treatment protocols? Do we have drugs? All these things need to be in place. And then if not, what are the barriers? So we went step by step and tried to address each of those barriers and put these processes in place. And then most importantly, how do we do the patient flow? When the patient comes in, who is directed to more peripheral and who is suppose they come to a PHC or a district hospital, then how they will be actually assigned back to their health wellness center. It's not simple at all because they need to be linked to the nurse there. So this nurse needs to know, okay, now this patient is under my care. And similarly, it also meant that there are patients who come to the health wellness center, but they may need to visit a PHC, let's say for doctor consultation, and then again come back. So setting this whole process and the health information system in place was part of one, doing it. But more importantly, when you are a researcher, you need to document it. And you also need to document whether you faced any challenges in doing it so that you know if you want to scale this approach, how will you do it? So there is a process documentation. And then there is also documentation of this process in terms of numbers. So as you can see in the chart here, we documented. So on the left, you can see people where they were taking treatment prior to implementation of this intervention and whether they shifted to the more facilities closer to their home. And as you can clearly see here, the patient from district hospitals and the patient from CHC and so on are moving more towards periphery. And more importantly, we also documented that after doing these changes, did we really bring about the desirable change in patient outcome, which is the ultimate test of whether our intervention is working or not. And as you can see here, I will just walk you through this chart. It's a little complex. So if you look at the topmost green color bars, these talk about over years, 4 years, 19, 20, 21, 22. What was the proportion of patients who were on treatment who had their blood pressure controlled? And as you can see here, we have district hospital, CHC, PHC, health wellness center. And in 2019, there were no health wellness center functional. So that's why you see a blank there. But you can see as the years went by, you can see that the blood pressure control was highest in the health wellness center. So what you saw in the previous slide is that the large number of patients move to health wellness center and they are taking care in health wellness centers. What you see in this slide is that the people who move to health wellness centers actually had better blood pressure control. So this is just an example, and since this is something I feel very relevant in the current context, as we are struggling more and more with the NCD burden, that we should be able to take the care closer and closer to patient homes. So similarly, I will be discussing with you few other research questions for you to get a sense of how to ask a question. So let's move on. And I have my colleague here, Dr. Ganesh. I will request him to discuss with me about the first question, which is on how can diabetes peer groups help improve treatment compliance and glycemic control. Dr. Ganesh works on a very large GSCD implementation research project where they are trying to see whether engaging and how do we engage better with the patient groups and how they can influence each other to improve glycemic control. So, Dr. Ganesh, I have two parts of my question. One is, how did you arrive at this question? And how did you move from this question to objectives of your study? Over to you, Dr. Ganesh.
Thank you. Thank you, Dr. Prabdeep. So, in our study, when we jointly did with the government of Tamil Nadu in order to improve the control, glycemic control of diabetes, when we were working in the field in its implementation on what are the factors which actually improves the control of diabetes, we figured it out that the most important determinant is compliance to the treatment, and the patient need to aware that they need to take drugs regularly on all the measures whichever being done by usually by the health system, where the patient usually visits the doctor or a healthcare worker. Apart from their counseling, then we found that there is an literature evidence where multiple RCTs been conducted, that a peer support group among the patients actually accelerates the compliance towards the treatment, and as well as it improves the control of diabetes by following some of the lifestyle practices. There was a fantastic cross learning which we have observed when we bring the patients together. So we went with this particular question that how a diabetes peer group could improve their treatment compliance by forming a kind of a peer support group program. And when we try to do that at the community level, we found that there are multiple dynamics which could influence them to cross learn when they are coming as a kind of a group and support each other. And we are trying to document that more in a factor, what are all the processes involved in order to bring this group together, and as well as what are the processes involved for make them to compliance with the drug treatment continuously, so that their care pathway also improves and their glycemic control also improves.
Thank you, Ganesh. Can you just tell for the benefit of the audience, maybe one or two objectives so that they understand how you framed your objectives?
Yeah. So when we first usually try to frame the objectives in our group, majority of time we land up in terms of trying to answer whether the peer support group program will improve the control, whereas we try to answer an implementation outcome, that how a peer support group program could improve the treatment compliance, and how peer support group program could improve the glycemic control of that. Rather than the routine of to determine the effectiveness of any intervention, we try to address that how actually this particular program, while being implemented in the respective context, could improve these two important determinants, which is compliance and as well as the glycemic control.
Thank you, Dr. Ganesh. So I think just to summarize, that was a beautiful example where we know that there has already been published literature that the peer groups can be very effective in the NCD interventions. But the question is, how do we form these groups? How these groups interact with each other? Do the dynamics go in a right way? And then how do we pick the right people to be facilitators for these groups? So these are all the process questions that you need to answer. Only then you will be able to make sure that your implementation is clearly understood by other researchers. So documenting that process will enable others to do similar interventions, because when you say I did the peer group and it worked, people can't understand how you did it, and they can't replicate the process. Hence, one, documenting the process, and second, measuring the outcomes using very objective indicators is really important. And I think, Dr. Ganesh, what's the outcome that you are measuring uh, to know whether your implementation is going as per the plan?
Yeah, so there are two important outcomes that we classically measure here. One of the outcome is that like usual the clinical outcomes, but the most important interest that which we had is the implementation outcomes, by we are adopting the re-aim framework for that, evaluating its reach, adoption, effectiveness, implementation, and maintenance of that. And we adopt this re-aim framework on this. However, in order to document the process on how we form the groups, how the groups interact, how the groups are actually doing this kind of like an spillover effect in the community, we have also adopted CFIR framework, which is consolidated framework for implementation research, in order to understand what are the different kind of characteristics of the population, the inner setting and outer setting, how they influence in terms of conduct of this particular peer support group program. So we highlight on all these implementation outcomes apart from the effectiveness in improving the compliance and glycemic control.
Thank you, Dr. Ganesh. That was very helpful, and you can ask more questions from him in the Q&A session. So let me move to the next question here now, which is again, we all know there are guidelines available for most of the diseases. And if you see in historically, we have seen huge success with the protocols in malaria and tuberculosis programs. However, as the NCD programs have evolved in the recent years, we mostly had guidelines which were extremely complex, and most of the doctors could not understand, especially in the primary care settings, how to implement those guidelines. So, what we have been doing in the past few years is to convert these guidelines into protocols, because protocols are easier to understand, they are simpler, and they are supposed to be one pagers, so you don't need to memorize them. So while we were working on these protocols, what we learned over time is that although we developed many of these protocols with expert consensus and considering the feasibility of implementing these protocols on the ground, however, in reality, when you start implementing these protocols, you do not always get desirable results, because theoretically they look all great, but things go wrong along the way when you implement them. So one of the important questions that we asked is, how do we optimize our treatment protocols for hypertension and diabetes to improve compliance and blood pressure control? So again, we have been working on this area. And here, if you design a study for this purpose, what you will essentially be looking at is, you have this protocol and you have actually given this to your doctors, and it's there in the field. You need to see to what extent it is being followed. And if it is not being followed, why is it not being followed? Is it because the doctors don't like the protocol? Is it because the drugs which you have mentioned in the protocol are not available? Yes, doctor like it, drugs are available, but patient is not taking the drugs, right? So there can be so many steps in the process that even though you have a great protocol, you are not getting the optimal control. So this is another very important sort of question that you can answer through implementation research. And we have done some publication around this, and we continue to work on this because we feel this is an extremely challenging area. Now I'll move to the third example. This is all in the domain of NCDs, and then I will also be addressing some of the examples from other domains. So this is again, we have now so many interventions in place. Like, we have a screening program going on, we have treatment going on, and so many other things. But how can we integrate a quality improvement initiative within our health system to improve treatment outcomes? So although we are treating people, although we are getting a lot of people on treatment, are we really achieving the results we want? And I have my colleague, Dr. Mogan, he and Dr. Archana have recently started working on this project. But what I would like, Dr. Mogan, for you to share with us is, how did you arrive at this question? And then taking the audience through that thinking process that went through reaching this question, and what are your objectives? Over to you.
Yeah, thank you, Dr. Prabdeep, ma'am, and it's good to have in the call. And before answering the question, I just want to re-emphasize that quality improvement initiative is not like an RCT or randomized control trial where we are going to test the intervention, whether it is happening or working good or it's giving a good results. So the quality improvement initiative is what the interventions we are going to implement in the program or at the field level, which have been already documented as a perfect one or as a good effective strategies. So here we are going after the RCT trials, which have been documented as a with very good initiatives in the programs. So I want to re-emphasize the statement which you have provided prior, Dr. Pradeep. So you have told that we know what interventions work based on the previous documented literatures, but whether those interventions were implemented at right time and right setting, whether it have been tweaked according to the program is the very important implementation part. So coming to our quality improvement project. So as a regular researcher, we started with the program data analysis of hypertension, where we found that the cascade of care of hypertension, in which among the total diagnosed hypertension, we found only 1/3 were aware of their status and only 15% were on treatment and only 10% of the people who are on diagnosed were on control. So this huge percentage gap was found to be due to the poor quality, which accounts for massive proportion of CVD deaths in low income countries. So based on the literature, we found that there was not one solution which could improve the program perspective in BP control. We found that there are multiple package of interventions which were found to be improving the BP control based on previous literatures. Also in Indian setting, the NPNCD program, which incorporates the hypertension disease, does not have an inbuilt QA strategy. Other countries such as UK, US have documented the QAs have improved the BP control and other programs outcomes. Based on this, we try to use one of the strategies in Madhya Pradesh of state where we found that the follow-up visits of hypertension have been improved with this quality improvement strategy. So we found that this idea of implementation into the NCD program could be more effective in future. So with this, we found that, okay, let's go with the quality improvement strategies with the package of intervention based on the setting specific problems. So based on these situations, we arrived with the two objectives. Firstly, to develop and embed a model of quality improvement for hypertension and diabetes at primary care level in selected districts of India. This was our primary objective. And secondly, we have identified to improve the proportion of BP control by 20% through QA initiatives among the hypertension enrolled in the specific centers of the specific selected districts, which we have taken into the protocol.
Thank you, Dr. Morgan. So again, I want to re-emphasize. So your first objective is more around documenting the process. And the second objective is understanding after implementing the process, whether you are actually able to change the outcomes. So that's the point I again want to drive home. So you can have multiple objectives in an implementation research project, but you need to make sure that the process is well documented. Thank you, Dr. Morgan, for your inputs. So as I move on to the next set of questions, which will be more around maternal, child, and adolescent health. So we have with us a great expert, Dr. Vishwajit here, who's been working a lot on child health. And I would like him to reflect. I know he's worked a lot on trying to embed kangaroo mother care practices in the neonatal health program. So I would like him to reflect on that and just share with us that how you were able to bridge that evidence to practice gap using these research questions, like how you actually arrived at these research questions and what were the objectives of various studies that you have undertaken in this area. Over to you, Dr. Vishwajit.
Thank you so much, Dr. Prabhdeep, and thank you and welcome all the participants. I can see we have over 100, and this is absolutely a delightful session. You're an amazing teacher, and I'm listening to you for the first time as a teacher. And I just wanted to take the opportunity and put you on a spot for a minute, because we all need to, just a round of applause and gratitude for the amazing work that you did with the India Hypertensive program. And just to let all the listeners know that you were recognized nationally for you and the entire team at ICMR and our institutes and other partners.
Thank
Grateful
you so much.
and congratulations. So
thank you.
My apologies for putting you in this spot for it. So no, thank you so much. This has been an incredibly educative for me just listening to you. And I was just reflecting on in the context of your research. And let's just pick up the issue of neonatal mortality in general and kangaroo mother care in particular. And so neonatal mortality is both a very important indicator of our overall development status of a nation. It's a very sensitive indicator as well. This has been important right from the Millennium Development Goals era, continues to be in this. So this is an imperative, a moral imperative that we absolutely have to address. And the good thing is that everyone across the world is united in this. Yeah. We also know how to reduce preventable neonatal deaths. So that's the best part. We know with very simple measures, we can actually reduce neonatal mortality by 2/3 to 3/4. But the big question that we have in general for the neonatal mortality landscape is what we know works, how do we make it work? And one of the key interventions is kangaroo mother care. For those who may not be fully aware, it's a practice where a mother puts her baby in a skin-to-skin contact. And it is primarily a recommendation for low birth weight babies, but any babies can actually receive it. Now, over the past 25 years, there has been a very systematic process of evidence generation globally. And it's very interesting because incubators actually came before kangaroo mother care, at least in its current form. And therefore, kangaroo mother care, the evidence generation process had to be very protracted because we had to actually demonstrate that it is at least as safe as incubators, then move on to say it's actually more beneficial than incubators. And you had to demonstrate this through randomized controlled trials across the world. The latest WHO recommendation actually puts kangaroo mother care at the top of the guidelines for the care of preterm and low birth weight babies. So it has taken a 25, and I just wanted to share this story with everyone listening here. That's the time that it took just for it to get there in our policy recommendation. Now, from a purely trialist perspective, you seem that your work is done, but from an implementation researcher perspective, your work just began. And so the question that we were asking, particularly for countries in South Asia and in Africa in particular, because we have very similar health system context, is how do we now take this life-saving intervention and make sure that at a population level, our mothers are indeed able, so that over 80% of these babies who need it, low birth weight babies, actually receive it. India has been very proactive. And so we had a policy in place. We had recommendations in place. So you had recommendations globally, you had recommendations nationally. So that barrier was done. So just to go back, as you started to explain, we had an evidence-based intervention in place whose efficacy was demonstrated in multiple geographies through multiple trials. Now, the next question was therefore, how do we now put this within the system? So the goal that we had set ourselves was, and the current Director General, he talked about, Dr. Rajiv Behel, and because he coordinated this global study, and the question we went about asking is, how do we develop a scalable district model where we can achieve greater than 80% high quality kangaroo mother care within our existing health system? And so the focus was on scale, the focus was on achieving population level, because not just in facility, but across the continuum from facility to home. And therefore it had implications of how we were measuring it as well. And so because we had 80%, didn't mean that we had to achieve it, but there was definitely an aspiration that we wanted to aim for. So this was what it is. In order to measure, in order to achieve that, the first key objective for us was to absolutely, as you said, process documentation. For us, it was created a protracted formative phase where we looked at all the current evidence, programmatic evidence that was placed, particularly in terms of our policy, in terms of our programs. And then, of course, research in order to understand the as-is of the system, barriers, facilitators. That then fed into the second objective, was to actually co-design a possible solution. In our case, we had multiple sites across the world, but one of the key findings that emerged was that, well, in our pursuit for neonatal mortality, we're missing the mother. So therefore, we needed to create some kind of a system that was centered around the mother, because she was the one who had to provide, care for prolonged periods of time. And then, of course, once we did it, and then when we realized that is not enough, we needed to have processes in place. So we had to completely reimagine the process, because for the first time, the mother and the baby were together. Mm-hmm. And so, these were just some of those. The third piece was actually the outcome, which was very important. In our case, we had some historical data on kangaroo mother care, and therefore we did not go for a quasi-experimental because it was already large. And so we did almost a time series basing on that baseline and continued to collect data both at the facility as well as the community, so that we could look at those data through follow-up. So this was how we actually wanted to look at the outcome in terms of kangaroo mother care. And of course, we had some other indicators as well. Are the babies being weighed? When are they being put to the mother's breast? When does breastfeeding start? How long, the duration, et cetera, et cetera. Now over to you for more questions and then I'll come.
Yeah. Thank you so much. So Dr. Vishwajit, I really like the point that, what you said, that once the evidence is generated, most researchers think their work is over. But for us in the world of implementation research, our work has just begun. I think that is such an important take-home message for all of you out there who want to work in this area, because you have to really look at it very long term. Taking a very simple intervention, like it may look so simple, oh, kangaroo mother care, like what's so exciting about it? I think I want to reinforce this, that quite often I find that the young medical graduates, they want to do something novel, something very unique, different. But the point is, your impact may come from very simple interventions. But just because they are simple, that does not mean it is simple to scale them. That does not mean it is simple to embed them in the health system. So, taking on from that, so I think now I know you are part of this national research program, which ICMR is working on. How do we sort of reach this single-digit neonatal mortality rate, wherein you need a set of intervention and not just one? And we know certain districts are lagging behind the other. As I mentioned in the earlier part of my talk, sometimes we know interventions are there. We know these interventions are working, but they just don't seem to be working the same way everywhere. In some places, it's like you are putting same ingredients, but you are not getting the same taste of your biryani or whatever be the food that you are cooking. So there is something that makes a difference, which is the context. And I think you can maybe elaborate a little more on this particular research question, how this was arrived, and what are your thoughts around doing implementation research on effective interventions within the country, which seem to be working in one place but may not be working in other places.
Awesome. This is great, because I think it goes back to your first set of observations or caution was that implementation research needs to be grounded in reality and it needs to be demand driven. So let me just begin from there, and I'll share that. But my other, I'm also looking at all the attendees, and I'm hoping that many of them are already, implementation research grantees, and those who are not, I'm hoping that they will apply to, ICMR grants that are, so I'm looking at both of those, and within that larger context, I'll explain this. Now, this is very interesting because all the national health research priority projects, let's begin with your first slide on being demand driven, being consultation with key stakeholders, and let me run through this. Now, usually what happens that one of the key barriers that researchers, all of us, face all the time, and part of the reason is researchers is always seen to be a lonely pursuit of researchers, which has very limited practical value to implementers. And therefore, all that they want is we go to the government and say, we have this study, and they would be very willingly or sometimes unwillingly, they would give you an approval, you go and do your work, publish it, very few people read it, at least those who need it most. Now, this was an opportunity where it was completely flipped. The Director General, ICMR, is also the Secretary, Department of Health Research, goes to the Secretary, Ministry of Health and Department of Ministry of Health and Family Welfare, the Secretary Health, and says, tell me, we are here to help. Tell me what are your most pernicious, the most difficult, more tenacious health challenges for the country. And there is a process through which, a consultative process, through which a set of key priorities for the country, where we have the evidence, but we are struggling in implementing it, is identified. One of them is, how do we reduce neonatal mortality? And so Niti Aayog and others all are part of this consultation. So that just goes back to you telling, did it meet that? Yes, I can tell you, Dr. Prabhdeep, that yes, I can checklist and I say, yes, I heard your lecture very well, and we did this. The second step was then, how do we do it? And so all the sites, so we chose multiple sites across the country. One, of course, looking at the capability of the investigators, but the second also so that it represents the large diversity of our country. And now, as you see, it's a single-digit neonatal mortality, which means there are some geographies that are already at 12, and some geographies are at 40. And we wanted the diversity. Just to all the listeners, I think here in this case, this diversity is absolutely a gift for implementation researchers, because that gives us clues that what works and what does not work. And therefore, we can always get so much more information and insights into taking things where it works and taking things to where it does not work. So it really becomes important. So therefore, it's very important not to see it as one site, but see it as a conglomeration of sites. Then our idea was, okay, let's look at what this is a priority, but what is the national aspiration? So India is an aspirational country, right? We want to do better than anybody else. And we are saying, well, reducing neonatal mortality by 10% is not good enough. 20% is not good enough. Let us set ourselves a mission, like just a mission to the moon. Let's go for the moon. Let's go for it. And so what did we come up with? We need to reduce it. We need to achieve a single-digit neonatal mortality. Now, this is very unlike. So this is an example where you can actually also put an aspiration, a national or a state aspiration there as part of the goal. The moment you have this common aspiration, it actually unites everyone. All the state governments want to be, this is something that we would like to achieve. Now, that is one key barrier that we need to achieve, because that's, as we said, this is implementation research. Implementers come first. Researchers are to the power of research. Implementers are in the driver's seat. Researchers are just the navigator sitting next to them, right? Now, so that's where we came up with this. And though this is essentially, how do we now, therefore, bring the best in science, bring the best in implementation science to identify implementation bottlenecks, fix it so that the system can be optimized, so that it can actually deliver better efficiency. right? So think of it like a vehicle which has been run down. We have been called as mechanics or implementation researchers. The first thing we will do is run the diagnostics through the system. Where are those opportunities where we can unclog? And that's where we start optimizing it. And so that's what we are intending to do here. So we have a district, and the district across the whole chain, we would like to understand here, what is the current neonatal mortality? What are they dying of? Where are they dying of? What is the process of care? And therefore identify which are those early wins that we can then support the health system to address. We don't want to solve all the problems, but we want to solve the problems which yields us higher efficiency in terms of neonatal mortality. So this is what we have embarked on, a very ambitious project. Over to you, Dr. Prabhu.
Thank you, Dr. Vishwajit. I really like you said that keyword unclog, right? So I think that's the whole idea, identifying where the barriers are, clearing those barriers, and then seeing, okay, maybe by doing that, does it really make things better? Because we may think it will work, but it may not. Or sometimes it may even work better than what we thought. So I think the good part of being implementation researcher is that you're always learning on the ground. So you can't go with the mindset of being an expert who knows it all. So it's really important to learn by observation and keep on tweaking whatever intervention you have set out to do. So your objectives, unlike the other studies where it is set in the stone, here your objectives are not set in the stone.
Absolutely.
And that's an important point I want to make. As you go from question to objective, you need to keep that flexibility to keep improving or evolving your interventions or strategies over a period of time. And even if it may happen that you go to the ground and you realize that you were totally wrong, and you should have the humility to take it. I'm so happy you brought that point, Dr. Vishwajit.
I'll make just quick point, Dr. Prabhdeep, and then I'll,
sure.
And then you can just do quick point that I think that might be very important for, all, we are all students in this and of implementation research. There's a study that it's an implementation research work that we're trying to get mothers into our special newborn care units. So we've heard of NICU, we want to add the M there. We want to bring the mother inside it. We've heard of SNCUs or special newborn care units, we want to bring the mother there. So there is a trial, a multi-country trial, again, coordinated by Dr. Rajiv when he was in WHO, published in NEJM, very powerful intervention. Brought the mother inside NICU, did the trial, over 30% reduction in neonatal mortality, absolutely. So this was a study, right? Efficacy study done under very controlled, high budget environment. Now we are moving into the implementation research. And this is just fresh off, we have not even published it, but I just wanted to share very quickly of how important. Now, what does it seem? Oh, this is here. Now we just need to put it in every hospital, right? We need to go in there and we need to put some beds and tweak something, do some training, and there it goes. We did this in a hospital. We had to re-engineer we realized we just need to completely re-engineer the facility for a facility that was just meant for the baby, and therefore you just had incubators. Now you had to bring in the mother. Number two, we had to completely manage the expectation of the whole mental model and the culture of care, because in that culture of care, I, as a doctor, had complete control. I was the king of that place where the mother would simply peep through the glass window outside. And now we're saying that the mothers are the primary caregivers inside an intensive care unit, for example, right? Which means there is more accountability, there is more visibility, right? There is everything. I cannot just take the baby somewhere, hide it, and just prick the baby, right? It completely changes it. Third and most important, we were there and they said, we used to have in the same incubator, we would keep double the babies or triple the babies, and all of you would have seen it. How do you do that on a bed? And so many government hospitals that cannot refuse admissions, what do? Right? So now, just imagine what you could see in an efficacy study. The moment you start doing it, you realize that, they're just encountering the most the challenges that we had never thought of. So I'll end with just last note that implementation research is also the link between the ground, from the realities in the ground, to the policies that are being made. So implementation research also becomes not just where there is a policy and how do we make it work, but also how we are making it work feeds back into policy design, so we make smarter and more relevant, policy design as well. So I'll stop here.
Thank you, Dr. Vishwa. That was a very, very interesting example where learning on the ground is so important. So I will be now running through a few other questions and then ending with some thoughts on objectives, and then we'll open it out to questions. So I think I'll wind up in the next couple of minutes. So the next very interesting research question, actually, this was suggested by one of the colleagues I recently met, and she's in the audience. I think I would request her to talk during the Q&A session. So she's working on so there is enough evidence that we can do mental health interventions involving healthcare workers, but how do we actually embed them into our health system? And that seems like an extremely challenging thing to me, because there is an adolescent health program. We have these adolescent health research friendly clinics, but can we really embed, can we build capacity of healthcare workers and make sure we are detecting these conditions early? And now, for those who work in infectious disease, shouldn't feel that we didn't talk about infectious disease. Hence, I kept few examples from my experience. So many of you were in the COVID vaccine programs, and you know that we had huge problems with the uptake of COVID vaccine in several parts of the country. So a good implementation research question could be around how can we improve the uptake, because vaccine is there, nurses are there to give the vaccine. And now what do? We assume we have done our job, but then people say, no, I don't want to get vaccinated. So understanding those barriers and then addressing, now those barriers could be people's perception about the vaccine, could be their ability to access the health facility. So that's what you will find out as you get on the ground, and then see, and then it could be different in different places as well. In one place, it could be access. In other place, it could be knowledge of community. In third place, it could be some adverse event that happened with someone, and hence people are not willing to take the vaccine. So you cannot go with the uniform ideas, and you have to adapt. The next very interesting area where I know recently there have been a lot of good implementation research work. We all know how to do infection control. We all know what are the good practices, but AMR, antimicrobial resistance, has been on rise. So how do we embed good practices in our hospital settings? And when I say that, the hospitals can be so different in India. When you look at secondary care versus tertiary care, when you look at public versus private, then how do we embed these good practices? We need to really learn it on the ground through IR. And finally, a very successful work has been done, and there's a lot of literature which you can refer to on how IR actually helped in improving uptake of insecticide-treated bed nets in the malarious districts in India as well as in several other countries. Here again, there were a lot of trials which showed that insecticide-treated bed nets were effective, and they did reduce malaria incidence. But there were huge challenges in making people actually use it. And I don't know if you have interacted with any malaria researchers. Some of them will tell you that people made it into fishing nets. People used it for everything other than what it was meant for, basically sleeping under the bed net, right? And finally, I know a lot of people like to work on tech nowadays, and we have been again having huge challenges with the tech. And I feel that's one area we need a lot of IR. So how do we embed these new information systems? One after the other, app comes, portal comes, and it's very top down. But when you go on the ground, you find that the health worker says, now suddenly I have another app, suddenly I have another information system. Now what do I do with it, right? That requires very good research and working with the users at all levels. Then optimizing the apps. So we know there are many apps, but then are they really friendly to those who are using it? And are they really helping us track the treatment outcomes for any disease? It could be for TB, hypertension, and so on. And the third important area where I feel a lot of work people are trying to do is telemedicine. And I feel now we have telemedicine in place, system is all there, but how do we optimize it? How do we optimize the use, especially at health wellness centers where doctor is not available, so that we are able to improve access to treatment? So now coming to the final set of slides, just talking little about objective. I think you heard from various investigators here, and you will have the opportunity to ask questions. But broadly, what I want you to reflect on is that once you have agreed on a question, you need to think about the objective. You can have an overarching objective, which says, let's say, describing the a set of or documenting whether a particular set of strategies are um, optimized and are improving certain patient outcomes. It could be child health, maternal health, NCDs, and so on. But then what you really need is you need to break down your objectives in the multiple parts, because if you do that, it will make it very easy for you to think through your methods. And unlike when we talk about a typical epidemiological study, we have one question and we have one method, like we have a cross-sectional survey, we have a case control study, or so we do one study, one method. In implementation research, you may end up using multiple methods, and you will be learning more about the methods in the subsequent webinars. But the point I'm trying to make is that you need to have these multiple objectives so that when you're writing your method section, you are not confused, because quite often people say, oh, what do I write? Should I write cross-sectional? Should I write cohort? No, it may not be any one study design. You may actually end up doing a cross-sectional survey to begin with. You may end up doing interviews with the stakeholders to understand what the challenges are, and may end up doing formative research. But then over a period of time, you may deploy multiple methods. This could be qualitative research methods or quantitative research methods. And most importantly, you may end up putting systems in place to measure your outcomes, which could be within the health system. For instance, you could adapt your information system, which is already there, so that you are able to measure your outcomes, and hence your objectives could be aligned along those outcomes. On the other hand, sometimes it may happen that you're not able to measure all of that, and you may be required to do additional surveys or additional data collection to know whether your intervention is working or not. So you can have a broad objective and then you can have sub-objective, but please remember, document the process, because end of the day, you need to know what, even if your intervention is a success, you should be able to explain other researchers and other policymakers or those who want to replicate your intervention, how you got it right. And trust me, it's much easier when things go wrong, but it's a lot more difficult to explain people what went right when the things go right. So documenting the process, you need to have very clearly set objectives. And finally, to end up, just to give you an example, these objectives could be around looking at various pillars of the health system. For instance, I shared with you something around how we looked at the decentralization process, which actually is about the health system levels and understanding how people move across these levels, right? So similarly, you may have a process around drug supply. There can be processes around, you just heard from Dr. Vishwajit, the process around re-engineering the health facilities to bring mother and baby together. It could be the process around what made certain groups accept an intervention who were earlier not accepting the interventions. And finally, there can be objectives which are measuring your various indicators and quantitative and qualitative outcomes. In the subsequent sessions, you will be learning more about the frameworks and methods, so I will not be talking too much about that. Just before I end, I wanted you to tell you about, there are a lot of resources out there, and I would really recommend reading them before you actually design your own studies. So this is a very good website, and I have put a link here, which is GSCD's website, which has these case studies based on various IR projects which are done in NCDs. You can read them to get an idea how to design your studies. And then there are also there are these kind of courses available from GSCD, which is called Implementation Science School. They advertise it every year. There is a MOOC done by the WHO, which is an online course. And then there are a lot of online resources available on University of Washington website and so on. So I will stop with this now, and we will be happy to take questions. Thank you very much, and it was a great opportunity to share my thoughts with you. Thanks a lot.
Thank you very much, ma'am. That is really an insightful discussion, more interactive and insightful discussion. We had a good insight on how actually we need to frame our research questions for implementation research, because that only decides the entire design of the implementation research, which decides the study, the sampling, which decides the implementation outcomes, that decides in terms of like expected outcomes also. We have some questions from the audience. I will direct to you that. One is that like one of the participants has asked that you mentioned about how and why is important to start implementation research. So when we know our research question while writing objectives, can we use the terms like to determine, to examine, to understand?
Yeah, very, very nice question. So typically as an epidemiologist, to determine, we use it when we are testing the hypothesis. Yes, to describe, to assess. Yes, the last one I missed, Ganesh, what was to understand? Yes, a lot of your process language when you use, it is usually around trying to understand. So yes, I do agree, but not so much to determine. It's like more when we write objectives for testing hypothesis, we say determine the risk factors. So that's not what we are trying to do here. And definitely not to use the things like to estimate a quantity. I think that's really important because those are descriptive study designs.
Thanks for that. One more question. What points we should keep in our mind while framing implementation research question with respect to guidelines implementation? So like introducing a newer guidelines into the public health practice, something like that.
Yeah. Yeah, actually, I gave an example on that. So I think the guidelines and protocols, again, what I mentioned, are quite often developed by experts. So they haven't gone through the grind of implementation research. So I think it's really important to actually do IR on guidelines and protocols, because once you have them, then you could ask questions around one, whether they are understood by your target group, whether it is doctors, nurses, and so on. Secondly, whether they need to be optimized. What I mean by optimized is that you thought that certain drugs need to be there, certain doses need to be there. But when you actually start using, you realize no. So I'll give you an example. Like we have been working on hypertension protocols, and we began with the 6-step protocol. And now our data shows that we should make it 4-step. So we wouldn't have known this, because when we talked to experts, they all said, no, you should have 6 steps, you should have these drugs, you should have these doses. But now we are actually talking to several of the implementers and suggesting them that they can further simplify these protocols. So yes, definitely you should do IR around protocols and guidelines.
Thank you very much for that. A last question related to, is there any risk of bias in implementation research?
Yes, definitely. I think whatever we keep in mind while designing any other research, we need to keep all of that in mind while designing implementation research as well. However, that is more something that you should keep in mind while working on your method section. And hence, I have not covered it here. But yes, there is a risk of bias. And one of the things to keep in mind, which I think Vishwajit mentioned, one way to ensure that your findings are more sort of applicable is to have multiple settings. Because if you do it in a very narrow one kind of environment, then your intervention just may not work in another environment or in another setting. So testing your implementation in diverse environments, in diverse contexts is a good idea.
Thank you. And now I request Dr. Kavita of Scientistry of Indian Council of Medical Research of Delivery Division for your closing remarks and as well as the take-home message.
Yeah, thank you, Dr. Ganesh. I would like to thank Prabhdeep ma'am for the very wonderful session. I hope it was very helpful for the audience as well. And this forms a base for the further forthcoming sessions. So all the recording of this session will be in the YouTube. And I hope you can share these recordings to, or you can refer your friends to, go through this if somebody else is interested and they were not able to attend this session today live.